The business office staff, the people that, as we have these shelter-in-place requirements by our governors, really need to get up to speed with being able to connect. The increased call volume from people who have never accessed staff remotely. I think in the first couple of days as we moved this forward last week, we had probably 1,000 to 1,200 calls just specifically from staff who are having access issues or trying to figure out how to get their dual authentication processes set up. As we talk about creating a DriveUp testing facility, what does that look like? What kind of technology do we have to put in place from a networking and infrastructure standpoint? Label printers, all the types of things that you need to actually have someone in the field doing clinical work.
We've built out areas that we're calling surge capacity areas, so taking units that were down for construction remodel or areas that could be converted and outfitting them with the needed equipment and technologies, as monitors, and then we use capsule neuron to bring the signal back to the EHR. So we're doing all those types of things in preparation, along with shoring up equipment inventories, parts, and then really the way we'll have to strategically shift and change our priorities related to equipment maintenance and preventative maintenance and those types of things if some of our staff start to turn up as infected.
And what we've developed at Holland is two teams, a Team A and a Team B. The first team is set up for Sunday through Tuesday. They have 3 12-hour days. And then our second team is Wednesday through Friday. So we are actually in our last day that we were completely together was last week. And now we're going to be in isolated 2 teams now until this crisis is over. What that helps to achieve is, again, isolate, minimize the potential risk. And in the event if one of the teams is infected, we are able to have a backup team then that can take on that full responsibility and help support our clinicians, fight and provide that care to their patients.
We've come down to essential employees only on site and managing as needed with remote telework or being at home on call. So it's quite a change for us. Of our HTM group, about 20% of them were able to go home immediately and telework, some of which were alternating home and on-site regardless, so we put that to full-time. We took the remaining staff, most of which are technicians, need to put their hands on the stuff to fix it, and we're at about 50% staffing on-site now. That's expected to reduce even more with the plan to stratify and rotate staff as needed on site with a very clear set of expectations for response times for those folks who may get called in.
What we need is a full feedback loop. Is how do we get that information that's available for that patient that a physician needs real time to diagnose something. Let's just think about the COVID. If you had the ability to take the patient's oxygen saturation and temperature and get that information back to you electronically via Bluetooth or something else, again, that would be something that they could do without having to interact with a caregiver. That information could be transmitted back to the provider's office, and then we would have a better sense of what the next option of care is. So when you talk about bang for your buck is, let's keep people safe and healthy. And if you're sick, how do we get information so that we can care for them the best way? And I think that some of that remote medical, having medical devices in the patient's home and being able to safely get information back for those caregivers is probably one of the big learnings, and I think something that we'll take and move forward with.